Okay, welcome everyone. Today the meeting hosts will be Dr. Swantai, Dr. Linda Adsen, and myself, Dr. Josep Rieda. And after the introduction, we'll have a talk from Professor Kovarik about teledermatology in Botswana, and then from the Professor Saenz regarding teledermatology in Venezuela. After that, we'll have time for questions and discussion. So your audio will be muted and your camera will be turned off for the duration of this webinar. Remember, there will be a live discussion after the presentation. If you have any questions or comments, please share via the chat function, and our meeting host will share this with the speakers at the end of the webinar. We will also be sharing some information about the GloDerm Training Committee in the chat function. I'm so happy to present today our two speakers. We have Dr. Carrie Kovarik. She is a professor of dermatology, dermatopathology, and infectious diseases at the University of Pennsylvania. Dr. Kovarik has a special interest in global and community health, infectious disease-related skin conditions, and improving access to healthcare through innovation and technology, including telemedicine and augmented intelligence. She has created the Penn Dermatology Global Health Program, through which she works to provide clinical care and education in underserved communities. Professor Kovarik has implemented numerous innovative programs with the goal of improving access to care and patient outcomes in underserved communities in the US and globally, using mobile phones, electronic medical records, open source technology, and accessory medical devices. She's now also focusing on developing sustainable and scalable interventions in healthcare that will improve the overall health of our communities, and her work spans many healthcare disciplines and types of technology. And after Professor Kovarik, we will have Dr. Ana Maria Saenz. She's a professor of dermatology and pediatric dermatology at the Universidad Central de Venezuela. Dr. Saenz is the vice president of the Venezuelan Dermatology Society and the editor-in-chief of Dermatología Venezolana, the only dermatology journal in the country. She has improved its periodicity and encouraged nationwide residency programs to publish it. Dr. Saenz is interested in general and pediatric dermatology, especially on vascular anomalies, bullous autoimmune diseases, and collagenous diseases. She's committed to providing dermatology care to disadvantaged populations, raising early career medical students' awareness of the dermatology specialty, and encouraging further telemedicine development in this field. So, thank you everyone for joining us, and let's hear Professor Kovarik.
Great, thank you so much for having us, and I'm excited that we have such a great group joining us from the audience and our diverse panelists here today. So I'm going to share my screen. Okay, so I'm going to talk about building access through technology. We're talking about teledermatology. I'm going to start by telling you a little bit, just really quickly, about skin disease in low resource settings. I think most people on this talk understand that because they are part of GloDerm, but just to build the scene, skin diseases really can cause a high burden of disease worldwide. We see, as we work in global health, that many of our patients in general healthcare complain about skin disease, and there's really very few trained dermatologists worldwide. And also, as people practice in global health, we see that the resources are really not allocated to manage these dermatologic conditions, and they fall short in a lot of developing countries. And so it's difficult to adequately manage these skin diseases. And Botswana is no different than many other countries that we are serving with our teledermatology. They have limited access to dermatologic care and often rely on foreign dermatologists and trainees. But I'll show you how this has gotten better over time. So just to set the stage of what Botswana has been like in their healthcare setting, This is what their organizational structure looks like. It's a public health center or health system in general. There is a private part of their health system, but in general, most citizens get public health care, and it's centrally organized. So this is the capital of Botswana. There's also another large hospital in Francistown, but Gaborone is really where the main city center hospital is located. And so there's these hubs of healthcare, and then you can see where the other red crosses are, where there's other smaller hospitals. So you have big hospitals and then smaller ones as you go out, and you have a large country with a population that's dispersed. And in order to get specialized health care, they start with these clinics and then go up in level of, excuse me, of acuity until some of them have to be referred to the largest healthcare center. And of course, there's challenges in getting inpatient beds and inefficiencies and trying to deliver adequate resources to the smaller healthcare centers. And so just to give you a snapshot of what we've been doing in Botswana over the years, we started working there in 2007 under Botswana-UPenn partnership. And in 2008, we started the American Academy of Dermatology Resident International Grant. We realized that there was one dermatologist providing care in the main city center. And we realized that if we started sending residents there, the residents would learn, but also they would help to assist the dermatologist that was there. And we sent them nonstop. There was no break in the resident that was on the ground. So they would overlap, and we sent about 15 to 18 a year. And that had continued until COVID. So the Resident International Grant's been going on about 14 years, and we've sent 160 or 70 residents now from US and Canada from about 65 programs. So it's been a very good program. So over time, the clinical coverage for dermatology care in Botswana has been by local dermatologists, Penn faculty, these residents, and in partnership with the University of Botswana, the medical school, local clinics, other departments. So we've been trying to build a community to ultimately have sustainable care there. We also have worked with the Ministry of Health to hire other local dermatologists. There's not a whole lot of local dermatologists. So we also have dermatologists from other African countries. And over time, we've partnered with them to help support them virtually, especially as COVID came up. So it's really been, doing what we can and helping them to reach, sustainability and independence over time. So I'm going to sort of take you on a little bit of a time machine venture in teledermatology to show you how we started. So thinking about how smartphones really started to penetrate the globe, it really wasn't that long ago. So this has shown how global devices penetrated. The blue is the PC, the red is the smartphone, and the green is tablets. So over time, this is from 2004 to 2013, you see how the PC is kind of leveled out and the smartphones really just went up. Just to remind you, the first iPhone was around 2009, 2010, and that's really where it started to take off. So when we started to develop teledermatology, especially with mobile phones, it was all right in this time frame. And if you look back in history, when big innovations really came about, it was when something like this happened. So the ability to have mobile phones penetrate in developing countries allowed us to have telemedicine also penetrate throughout developing countries. And those of you who either live in a developing country or low resource country or have been to one know that this is true. Mobile growth is just incredible. So people with mobile phones, 5.4 billion or 69% of the global population, whereas people with running water is almost half of that. So people have smartphones, but they may not have a car, a landline, or running water. So when we first realized we could do teledermatology on a phone, phones really leapfrogged over the physical computer in low resource settings because computers had viruses, they weren't maintained, but the phone was a new device that you could do this on. So as cell phone towers started to go up, we realized we could do teledermatology on these phones. So in about 2012, there was the Samsung phone, which was not a smartphone. It was a feature phone, but it had an 8-megapixel camera on it. So we did this study and showed that we could actually do teledermatology on a non-smartphone. This is a screenshot of what they could pick. The user could pick the age of the patient, how long did they have this condition, where was it? So it was a little bit less, put in the history and the physical. You kind of didn't have as many choices, but in the beginning of technologies, you're kind of doing what you can just to show that this would work. So basically you would go through the little screens and then you would take the photos and they would meet in cyberspace on the back end, and the dermatologist would see the information and answer the consult. And this is what they would see, the photos and the information. So this was published in 2014, but we did it a couple years before. But just for the young people out there, dermatologists were developing these things, and that was a time to realize, okay, well, we can collaborate with other specialties to use what we know to also advance other specialties. So we started to collaborate with other specialties. We developed a smartphone application to track antiretroviral medications for HIV on smartphones. We started to help to streamline things like mobile health tracking for tuberculosis contact tracing in Botswana on our non-smartphones using something called ODK Collect. So because we were starting to use smartphones for dermatology, we also realized we could help our colleagues in other ways. So another big place where we could help out in Botswana was with the residents and medical students. So a lot of them were sent out to clinics where they didn't have a lot of learning resources. The libraries didn't have books. They didn't really have smartphones with any kind of medical education on them. So we gave them smartphones or tablets, and the library at the University of Botswana helped them to download resources so that when they went out to clinics, they could actually look up medical information at the bedside. And this is some of the big, what we called in-learning tablet trainings, where we would help them to download the medical information. And we also use this to help with telemedicine consults to their mentors. So if they were at a site, they could actually send consults to their mentors for questions. And so as this evolved, we've also played a role there in Botswana in training of the University of Botswana medical students and residents. They rotate through the dermatology clinics, and there's a great need for them to learn on skin of color. That's really all they see there. But as you know, there's a lack of resources in skin of color. And so we partnered with this group at UCLA who had been doing these great modules that help students to learn in a really unique way. So what they do is they have these online image-based modules that help the individually help the student to learn about pattern recognition. So what we do is we have all of these images, and they rapidly go through these images, and if they get it right, they may not see many more of that type of macular papular rash. But if they get it wrong, the algorithm will keep showing them similar examples of that type of rash until they get it right. And it's shown in some studies that that kind of continual exposure to certain photos will give them longer, like they'll remember these things for longer. So here's an example. This is one picture that will come up as the students are going through these modules, and they have to pick, well, what is the morphology? So if the student answers this very quickly and gets it right, that will kind of be pushed aside and they won't get that one again. So the module will look at it for accuracy, but also what we call fluency, so accuracy within a target time. And we have these for diagnoses and for morphology. And we just did a little study to show that in Botswana, it's a 5-year medical school training, and we have the MS4s come through our clinic, and they did the modules before they did the rotation, and then we had them do a post-test many months after they did the modules and the rotation was finished. And they did very well in that delayed post-test, sort of showing that they retain the information for many, many months after, which we felt was like a durable gain of information. So switching gears to really how to make sure that you're scaling up sustainable teledermatology care. Some of the things that we learned or thought about over years was, the first thing is creating durable health IT infrastructure. So when we first came to Botswana, it was really hard to get the healthcare infrastructure durable, because Botswana is a landlocked country and they have to buy their web stuff from South Africa. It all comes up from South Africa and from Namibia. So trying to figure out how to do that and thinking about why everything's slow and really going to the heart of it all is kind of difficult. But beyond that, thinking about other sustainable things, training the healthcare workers, the medical students, and the residents on what health technology they can use and what's relevant for their work. And also then when we develop the teledermatology, we need to make sure that it works for the local infrastructure. So when we first started developing it, we had to identify partners that would champion the efforts and making sure that it's something that they want, like not that we're coming in and doing something that we want, but what is it that they need and want. And also using local platforms that they're familiar with. So making sure that we're not bringing in some huge clunky equipment that's going to just sit there and not be used. And also in understanding the inherent challenges of local resource limitations. So if someone's going to be answering the consult, they understand how to give a relevant answer back to the doctor, not something that's not going to make sense. And also follow-up, there should be someone available if there's an answer or a question from the submitting clinician. There should always be that availability for a back and forth discussion if the patient has some problem, and the clinician shouldn't just be left with no ability to ask. So this was the health IT part of it. So we had to really work hard to work with the Ministry of Health to sort of streamline I think when we first started, there were 81 different little portals and little siloed IT infrastructures within the Ministry of Health, none of which were talking to each other. So we started training people in health IT and kind of trying to integrate everything, which was helpful for telemedicine, and also getting a e-health government policy together, which has taken many, many years, but has paid off in the end. And then with our Botswana telemedicine program, we've also partnered with other specialties because, again, once dermatology was up, we could benefit other specialties. It was very easy to roll that out to other visual specialties. And then we also had teledermatopathology because I'm a pathologist, and we've had several different types of dermatopathology over the years. And again, because of the hierarchical type of healthcare, where the patient starts from the village and goes to the health post and then to the district hospital, one thing we thought would be useful was to equip the district hospitals with teledermatology, who could then consult the next layer of healthcare up, who could then consult the next layer of healthcare up, so people would not feel as isolated. So just thinking about the infrastructure in your setting and how it would be best utilized in your area. Also partnering with other local businesses. So we partnered with the local cell phone company to help us with cell phone cards for people who wouldn't be able to afford to submit photos all the time. Not everyone in Botswana has endless data, and that was very helpful. So getting our leadership and their leadership to work together. We also partnered with Microsoft on a project which used these antennas in our district hospitals to launch something called TV White Space, where high-speed internet was launched over what we call white space, which is those old TV channels when on the U channel, where it's like that old, we don't even use it anymore. That's why they use it here. It would launch high-speed Wi-Fi over that old channel for about 10 miles. And so it would help us get Wi-Fi in these district hospitals so we could have better telemedicine in those very remote areas. But ultimately, one of our best programs was our simplest one. Dr. Tori Williams has been really instrumental in this. It's using WhatsApp for telederm. And that's because that's what people use in Botswana for communication. And really, in the end, like I said at the beginning, meeting people where they are to get patient outcomes as good as we can has been the best thing that we could do. So this is an example of a consultation from a referring provider who sent this. It was psoriasis versus eczema, and Tori's Dr. Williams is telling them kind of how to tell the difference. We even talk to our patients over WhatsApp. We have patients that live 10 hours away and have severe diseases. We have patients, this patient has pemphigus, and 5 years ago, we couldn't really put our patients on high doses of immunosuppressants and not worry about them because sometimes they wouldn't come back or they couldn't come back, and now we can communicate with them through WhatsApp and follow up with them. We use it for triage and coordination of care. So this is a patient with albinism. We can send the photos to the surgeons and they can help coordinate the surgeries. And it's just a very good tool for consultation and coordination. And it's got a very good encryption. So just to close, I just have a couple photos of some of my teledermatology photos. This is a patient from Lesotho, one of the very close by countries, with one of the worst cases of crusted scabies I had seen in a patient. This boy had HIV, but we had to be very innovative. There was no ivermectin in the country, so we partnered with one of the veterinary clinics to get him ivermectin, and he cleared with that. Here's a couple pictures of neoplasms. This is a large basal cell in a patient with albinism that's sort of pulling down on his eye. This is a large pigmented Bowen's, but you can see the scalloped border here. This is a large acral melanoma. This is a child with a tumoral bacillary angiomatosis, which cleared in 2 weeks with oral erythromycin. So at first they wanted to cut this out. We thought, well, it could also be Kaposi sarcoma, but erythromycin is always a good first line to try before you do anything else in these patients. This is a patient with tumoral CTCL. You can see the patch and plaque stages. This patient also had HIV. This was from Francistown in Botswana. This is a really interesting patient. This patient had major apathy, which is a HIV, a WHO criteria, and HIV and I said that already. But this patient actually cleared with dapsone. You can see from here to here, this is a really challenging patient because you kind of hesitate to put people on dapsone, but that was ultimately what we cleared him with. And this is a little boy with HIV who had what we finally figured out was disseminated blasto. But before I could tell them to start him on ampho, they decided to cut the lesions out. But we finally got him on the medication and he did very well. And I have permission to show these photos. And he's doing well, but sometimes the communication you can't get fast enough before the care is continued locally. It's just the way it sometimes is, but he's doing really well. And that's it.
Well, thank you very much for your excellent talk. I think there are many, many questions, but we will discuss them later. Now is the time to hear Professor Saenz. She will talk about their experience in teledermatology in Venezuela.
Hello, good morning, good afternoon, everyone. Thank you for the invitation to participate in this talk. I am Ana María Saenz from Caracas, Venezuela, Universidad Central de Venezuela, and located in the Hospital Universitario de Caracas. First of all, I would like to show you where our country is located. Aquí no me pasa la diapositiva.
No, tienes que compartir primero.
Ah, perdón. Perdón, aquí. Listo.
Dale, quise.
Yeah, are you seeing? Are you watching?
Yeah, perfectly.
Okay. So first of all, I would like to tell you where our country is located. Venezuela is located in the north part of South America, bordering with Colombia and Brazil, and also with the Caribbean Sea and English Guyana. Most of the developed cities, no me pasa la diapositiva.
Tienes que darle clic para que esté dale clic, y ahora sigue la diapositiva con
Most of the most important cities are located in the northern region of the country, and the south sections of the country are isolated and there are a lack of public services in this area. The estimated population before the large migration is almost 30 million people, mostly young population in Venezuela. Before 2012, Venezuela had the highest GDP per capita in Latin America. So from 2012, this GDP started to decline very, very fast. And until 2020, it went down to 60 to 70%. As a result, all the poverty rates declined and the situation of the country got very, very difficult. So a lot of people migrated the country, almost 5 million people were looking for better conditions and were leaving the country, and there was a shortage on basic products, including medical products, health products, and basic products. And also there was a low quality of public services. There was no water, there was no electricity, cooking gas, even gasoline to attend. So that's why a lot of people left the country, including our health personnel, because there were inadequate salaries, there was working conditions very, very bad, especially in public hospitals. So it was like a very terrible humanitarian crisis. So all the doctors started to immigrate, and around 1/3 of all physicians left the country, and it's calculated that from 2014 and 2019, the emigration was near 30,000 physicians that, of all specialties, left Venezuela. So not only doctors, also health professionals like nurses, laboratory technicians, paramedics. So it was a very, very bad situation in our public hospital, which is the major system that attend the population of Venezuela. So we are in the Universidad Central Venezuela, one is the major universities of the country, the most important universities, and we're one of the major medical schools in our country. From that university, there have been having projects to try to solve this terrible situation that we are going through. So especially to the most vulnerable population that are located in the south parts of the country, the indigenous, also at the borders of Colombia to Venezuela, that are very, very poor people. So we had to decide to make projects to attend, to give them services, health services to these very far located people. So telemedicine is one of the answers to help these people to receive health services where the distance is a critical factor. So you know that telemedicine is good not only for developing countries like Venezuela, but also for developed countries. In the Universidad Central de Venezuela, since 20 years ago, I started the telemedicine project. We have been working all these years until the 2007, created the SOS Telemedicine, which they start with a very, very good team of people, composed by the chief of Dr. Arrechedera, composed of many engineers, electrical engineers, civilian engineers, computer engineers, and also doctors from all other specialties, design projects to help to do telemedicine to Venezuela. So they installed a lot of antennas to the most distant places in our country, even in the Amazonia, to reach these people that were lacking of health services there. So a total of 39 operative centers were located in different sections of Venezuela, as you can see there, in the border of Colombia and Zulia state, and also in the Amazonia, very far end of the south of Venezuela, and in the Nueva Esparta state, and others in the central area of Venezuela. So they attend these people that were lacking of any health service by the moment, especially with all conditions and skin conditions. So they also educate health personnel that were working there to manage to handle these new technologies, so they could help and they could send the information to the Universidad Central de Venezuela, where the main platform was located, so they could get and receive information and help to solve the main problems that these people have. So they also created the telemedicine e-learning platform, which is a very huge platform that they have, including a YouTube channel, video conferences, clinical cases discussion, and short courses. There are a total of 19 courses online that have been doing this all years, and also the YouTube channel has been having more than 25 million views with 892 videos, and there have been 68K subscriptors, with a very, very acceptability of this. With the pandemic, they create also videos that help people to manage to deal with this pandemic. And also, with this pandemic, there also all the public hospitals, with the humanitarian crisis that were these hospitals, they created the SOS calls, will help with deal with patients with COVID-19 and also with other disease, because the poor people couldn't get into the hospitals. They were almost closed because they were only to attend COVID patients. So with this system, the Universidad Central de Venezuela helped people, and in total they have reached more than 50,000 calls. And that was managed by doctors, general doctors and practitioners, and specialty doctors that will help to respond to answer the calls that these people were taking. So what is dermatology doing here? Dermatology is a service, this is where I work, is located on the Hospital Universitario de Caracas, It's one of our resident programs of the 3 that are in the Universidad Central de Venezuela. This is a reference center because it's the only service that has hospitalization for skin diseases patients. So we are patients from all over the country. So during the pandemic, we have to change our way of seeing people, trying to help them, because it was a very terrible crisis. So we did a real-time consultation, giving consultation especially through the WhatsApp, which is an application. And we also did the in-store and forward teledermatology, trying to see an image from others, from patients, and also from other colleagues that were having problems with patients that they needed our help as a reference center. So in 2012 and 2013, we did our first approach to teledermatology with SOS telemedicine. We did a lot with this, creating the platform. But of course, the huge crisis got us, and we couldn't finish the beautiful program Dr. Arrechedera had with us. So, but we started doing the dermatology clinic history. As you can see, this was the project with the image of patients and everything, trying to connect with the platform they have already installed in the university. So with the pandemic, we also realized how important is teledermatology to all people, not only to Venezuela, but globally, to all the world. We start receiving pictures and images of patients from all over, and our residents were looking for our help through this way. And as you can see, these are some examples that residents and also people were sending image with some clinical information that we could help them to solve the problem as soon as possible, because they couldn't reach the hospitals. So we had to get partnership with Universidad Central de Venezuela, with Universidad Federal Santa Catarina from Brazil, and also with Universidad of Pennsylvania, to try to create a teledermatology platform to adapt this telemedicine to the Venezuelan content and dermatology specialty. And we need to operationalize the dermatology platform, develop operative manuals and templates for recording the medical history, and we have to pilot the project at small scale and adapt based on lessons learned, and include all dermatology specialty programs from national universities to teledermatology. And of course, we have to scale the project nationwide. So in sum, as I told you in my my first slide is the past. I have told you about the past, the present, and the future of dermatology. The teledermatology is the future of dermatology because it's one of the most important and commonly used areas of telemedicine, and we are responsible to giving answers to people suffering from skin diseases. And through teledermatology, we could help people not only in our country, but all over the world. So thank you very much for your attention. Stop sharing.
Thank you very much for your excellent talk, Professor Saenz. These two presentations were just showing how teledermatology can help us in different countries and different areas. So let's hear the questions we have from the audience and from the registrants. We cannot hear you, Aswan.
Oh, sorry. So I will just, I'm so sorry. I'll just start. So thank you very much for the great sessions. So we have received actually many questions from the registrants. Unfortunately, due to that time constraint, I just have I've picked a few for now, and then we can pick a few from the audience. So the first one that I have for both of you is, how do you best approach teledermatology in areas with poor internet connection or equipment with low resolution?
You can go first, Dr. Saenz.
Okay, well, that's a major problem we have in Venezuela. The internet connections are very unstable. So we have to try to do with our data of these mobile phones. That's the way we try to pass the image to us to try to help. That's the best way. Of course, there are centers that we have good internets, like the Universidad Central, but that we could use to improve our answer to respond of patients. But of course, what we do mostly is through our mobile, our phones. That's the internet we use.
Right, and I would also say that we've pretty much moved to mobile, and anytime you're thinking about implementing a program, you need to assess the capabilities of the people that will be sending the consults and look at where they'll be coming from so that you don't expect them to send consults from a desktop and they don't have adequate internet. So kind of do an assessment in that way.
Great, thank you. And the second questions that we have from the list is, how do we overcome the challenges with detailed examinations in teledermatology?
Can you repeat that with the what?
So basically, because in dermatology, we tend to have detailed examinations. So how do we overcome this restrictions in teledermatology?
With the examination, I didn't get the first word. What examinations?
So because usually in dermatology, in clinical examinations, we tend to feel, look, but in teledermatology, it's hard for us to actually have a view and have a view of like the lesions. So
okay.
Yeah, so people are wondering like, how can we overcome this?
Right. Well, the teledermatology is inherently limited in that way. So the best thing we can do is give instructions or educate the people that will be submitting the photos so that they can give us the best information possible. So for our patients, we have instructions, some very simple instructions on giving us like a far away picture and a close-up picture of a rash or a lesion, submitting as many photos as possible. Although in resource limited settings, you don't want to make people submit 10 photos and then have to wait. So it's a balance of numbers of photos and images and types of photos. So it really is a balancing act of getting the good photos that you want and not getting too many and making people frustrated with uploading them. Right.
Yeah, well, I would say that there are conditions that are very easily to diagnose, Carrie, like, for example, the neoplastic lesions are very easy to diagnose, and we can just deliver the patient to look for forward attention, directly, okay? But of course, with inflammatory diseases, it's more difficult. And I think the expertise of the person, the dermatologist, is very important. That's why we do have to have the residency programs, the doctors that are specialists that are, in the academic areas where they can conduct or they can educate their residents to answer those questions to people. I mean, it's expertise people. They could know exactly what questions they have to ask to the patient to make a right diagnosis. I don't know if you got what I have to say. I mean, with the years of experience, the doctors, dermatologists can rapidly answer or give an answer to a patient with a skin condition. Of course, there are some cases that is impossible, or sometimes it depends on the photo you have received. Sometimes it's not very good quality, and dermatologists can make any diagnose. So I don't know if you agree with me, Carrie, but that sometimes happens to us. Sometimes we cannot. We are like responsible. We feel that we better not answer because we could make a mistake and it could be, bad for patients. So sometimes it's very easy, sometimes it's not very easy to diagnose, depending on the photograph they sent us to us and the clinical history of the patient.
Right, you can just do the best that you can and be as transparent as possible and let them know the limitations. This is what I think, but with this photo, I'm, not sure, and you need maybe do this, this, and this. And, I think the provider sending it needs to know the limitations as well.
Exactly.
Thank you.
Yeah.
Thank you. Oh, so to further this question, which platform or software do you recommend for dermatology? I know both of you mentioned about WhatsApp. Is there anything, any other like software or platform would you recommend?
It's difficult because WhatsApp isn't really a teledermatology platform. So the best thing truly for teledermatology is a platform that integrates with the medical record that you're using. You want someone to send a photo that integrates into the record. But the problem is that's not always available, and especially in resource limited settings. And so you have to think hierarchical about what I'm trying to accomplish, what the setting is that I'm working in, and what can we actually do here. In Botswana, we tried to do something like that, and right now it's just not possible. And so at this point, we're trying to just get care to these patients and get, their surgeries accomplished. And at some other point, maybe we can have something that integrates into the medical record.
Yeah, there's also not a legal, in Venezuela, legal base to, that's the problem. Sometimes we don't know legally how we are supported. There's no legal, let's see, platform of seeing patients through this. It's better to create a special dermatology platform to attend, to receive this patient this way. I mean, with teledermatology seriously made. I mean, it's because of the prices. The fastest way is the WhatsApp application, but of course it must be a special application to do better teledermatology, specially created to that for that. Mm-hmm.
Thank you. I think probably each country will have a little bit different from how to set up the platform as well. And now I'll pass on to Linda to raise some questions that we have from the attendees today.
Hi, everyone. Good afternoon. Thank you so much for the responses so far. So we just have a few questions in the box. However, there were some questions that were also sent in, I think, quite interesting. So someone asks, how do you harmonize the legal techniques, I mean, with teledermatology and the legal implications? How would you put that together? And then also looking at dermoscopy, I mean, is it replacing dermoscopy in the examination of patients?
So the question is about legal implications in dermoscopy?
Yeah.
So in most of the stuff I do, we're not to the dermoscopy level. We're really at the, just getting photos to us for some kind of diagnosis. Dermoscopy is a little more sophisticated, and we're not there yet. Really, I'm just trying to get patients or providers in really low resource settings to send me photos on the phone. But, there are dermatoscopic devices that even hook up to iPhones. And so if that's what you're trying to do, it's definitely feasible at this point. the legal implication, the legal ramifications are different for there's just like no unifying legal rules. It's different in every country. It's different for every program. And so in each country that you're working, you have to work with the government, the Ministry of Health, the local organizations. In Botswana, we worked with the ministry, the University of Botswana, the local hospitals, to figure out exactly what we had to do. And it's different everywhere. The consent processes, the MOUs, it's very, you can't just sort of start and just do it. So you just have to make sure all your I's are dotted and T's are crossed.
Okay. All right. Thank you. So we have the next question. Says, which skin conditions did you find difficult to assess via teledermatology? From the audience.
Sorry, I'm having trouble hearing you. I'm sorry. Which what?
Okay. Which skin conditions did you find difficult to assess via teledermatology?
Yeah. Okay. But, as I told you, the most difficult conditions are the inflammatory skin conditions. I think the best are the neoplasia and the cancer. Skin cancer is quite easily to diagnose through a photograph. But the inflammatory conditions need like a clinical history and more data to try to diagnose correctly what we are what we are seeing. Of course, sometimes with the expertise of the dermatologist, we could get close to the diagnosis, but sometimes the final diagnosis is not very easy in quite a few cases. But we really did help, for example, in irritant contact dermatitis. We could do first thing to people and then tell them you have to clear up this, and then we'll see you in 5 days to see what is the first lesion that you had, because in Venezuela people usually that have something in skin, they put something. They never leave it alone. So we always, they always put something. They say, I didn't do anything, but they have done, of course. We know they're lying because we see that they have a irritant contact dermatitis. So we say, you do this as an irritant contact dermatitis, and then we'll see you back in 3-4 days, and then we'll see the initial lesion, and then we can help you. But the inflammatories are really sometimes a problem to treat. Yeah, but we do a lot of help with teledermatology. Really.
Okay. Thank you so much. Okay. Thank you so much. Dr. Kovarik, someone asks if testing module for skin of color is available for public use, and where can we access this? And then there's also another question that follows that to say, are these tools standardized, and how can we use them for research?
Yeah, so they have been developed. They're run through UCLA. So if you're interested in them, I put my email up. Send me an email and I'll direct you on how to access those modules. Yeah, you have to register for them and contact the people that developed them, but I believe you can access them if you're a resident or a trainee.
Okay, so how do you use them for research? Okay.
I don't know if you can use them for research, but I know you can use them as a trainee.
Okay. Are there metrics to measure success for teledermatology, the various platforms?
So there's, the teledermatology has been measured endlessly. It's definitely something that has been studied very well. So we know that it works if it's done properly. The papers are definitely out there, but I think it's more you need to make sure that it's set up properly when you do it.
Okay, and then I think the last question we have in here, maybe not the last, but do patients pay for these consultations, or are they covered by insurance?
You want to take that one? Dr. Saenz?
Yeah. I didn't understand what did she ask. Sorry.
Do patients pay for these consults?
No, anything. They don't pay. Yeah. In Venezuela, we have a public service. All we do in Hospital Universitario de Caracas is free. It's all public health service. And even our salaries in the doctors and the professors' salaries are very low right now in Venezuela. An incentive of the teledermatology, it will be something like that so we can engage more specialists to work with us, especially our students that are gone. They could help us from other countries getting a little bit, but I mean, that's the future. That's the future. Right now we have to solve our real problems that we have today, but we don't charge anything for this, really. We don't charge anything.
Great. Thank you very much. I think I'm handing over to Joseph. Thank you.
Thank you very much for your talks and for your wonderful presentations, and also for the discussion. I think has been very, very important, the part of the discussion, because there were many questions. So thank you very much again. And I will share the screen just for the upcoming event. Okay, here we have. So what we have the next month, we will have a Lancet Nigeria Commission webinar on the 16th of March, and the next GlowDerm Trainee Committee session will be on supervision of mentorship. What's the difference? Maximizing my development as a dermatologist, which will be online as the other ones next 26th of April. And we will have Professor Mini Singh, Professor Koza Dulova, and Dr. Tamara Griffiths. So that's all for today. Thank you very much for your participation, and again for your talks, Professor Saenz and Professor Kovarik. Thank you very much.
Yeah,
Thank you.
Yeah, looking forward to see you in Boston at the AAD,
Yes.
right? Okay,
Yeah,
bye-bye.
we have to make
Thank
it.
you.
Bye
Take
bye.
care. Bye.
Bye, everyone.
Thank you.
Ele cai, saiu em casa.
Assim?
Sim,
Borro aqui?
sim.
Uhum.